Mr. President, and thank you to ESHRE for giving us the opportunity to present our results on this RCT, also comparing a natural cycle versus an artificial cycle for endometrial preparation in frozen embryo transfer cycles in ovulatory women. Indeed, the title is more or less copy-paste, but the population is different. These are my disclosures. However, this RCT was not sponsored by industry, but was academically funded. So, as we are all aware, the number of FET cycles are increasing significantly in the last years, and with that, the pregnancy rates are also increasing in FET cycles, being now higher than the pregnancy rates in fresh cycles. There are different ways to prepare the endometrium in FET cycles, as we heard already from the previous speaker. In the natural cycle, we use the spontaneous ovulation to time embryo transfer. In a modified natural cycle, we give HCG to trigger the ovulation, and in an artificial cycle, estrogens and progesterones are administered consecutively. Last month, this Cochrane review was updated and published, and it showed no favor of one method over the other in terms of pregnancy rates. However, the authors of this Cochrane review concluded that the quality of the studies included in this review was low. So they state that more well-conducted RCTs are needed. Last year, there was also this RCT from Vietnam showing no differences in live birth rate between natural cycle, modified natural cycle, or artificial cycle. And then, as we heard already many times during the conference, there are some concerns about obstetric complications linked to artificial cycle FET since a couple of years, and the number of studies are getting really high, which is also shown in this meta-analysis from 2023. We got some really nice data at this conference, but we have to keep in mind that until 2023, the quality of these studies was still very low to moderate, according to these reviewers. So we have designed an open-label RCT comparing natural cycle FET and artificial cycle FET in 5 Belgian fertility centers. Primary outcome of our RCT was the clinical pregnancy rate with fetal heartbeat, analyzed as intention to treat. And then there are also some secondary outcomes, including live birth rate and also obstetric outcomes. As we are still waiting for the last patients to deliver in our RCT, I can only give you some interim results on the live birth rate and obstetric outcomes today. We have included patients between 18 and 45 years with regular ovulatory cycles, undergoing single or double embryo transfer of day 3 embryos or blastocysts in their first, second, or third IVF-ICSI attempt. Exclusion criteria were a short luteal phase or any signs of luteal insufficiency, an abnormal uterine cavity, the use of donor gametes, high BMI, or any medical contraindication to hormonal administration. We used the web-based randomization at the start of the FET cycle, and the aim was to include 554 patients to find a difference in clinical pregnancy rate of 10% with 80% power and 5% significance level. For the natural cycle, we use a truly natural cycle, meaning no HCG trigger and also no luteal phase support. And for the artificial cycle, patients received estradiol valerate orally, 6 milligrams from cycle day 2. The dose was increased to 8 milligrams after 1 week if the endometrial thickness did not reach 7 millimeters. And vaginal micronized progesterone was given once the endometrium was 7 millimeters. If the patient was pregnant in this group, hormonal treatment was continued until 12 weeks of gestation. This is the RCT flow chart. The time of recruitment took a bit longer than expected as we had quite a lot of patients who declined participation to this RCT, most of them because they preferred a natural cycle themselves, but also some of them preferred an artificial cycle. So in the end, we randomized 561 patients that were used for our intention to treat analysis. Not all patients got embryo transfer. As you can see, we had more cancellations in the artificial cycle than in the natural cycle. And the main reason for cancellation was thin endometrium or premature ovulation. There were also some patients who switched from one group to the other after randomization. So these are the number of patients that we could use for the as-treated analysis. The demographic characteristics were well balanced between the two groups. As you can see, the mean age was around 34 years, and also the other characteristics were well balanced. Indications for IVF-ICSI were also similar in both groups. When we look at the cycle characteristics, I've told you already that the number of cancellations, so women who got no embryo transfer, was higher in the artificial cycle group. But for the rest, the vast majority of patients received single embryo transfer. Most patients were transferred with a blastocyst, but some patients also received a cleavage stage embryo that was frozen in older, fresh cycles. So this is our primary outcome, the clinical pregnancy rate with fetal heartbeat in the intention to treat analysis. And as you can see here, the rates are not statistically significant different. Also in the as-treated group, clinical pregnancy rate was not different in the natural cycle compared to the artificial cycle. For the secondary outcomes, we've discussed already the cycle cancellation rate, which was higher in the artificial group. In the natural cycle group, patients needed more clinical visits to monitor the fat cycle, and endometrial thickness was similar in both groups. Then for the other pregnancy outcomes were not significantly different between the two groups. So pregnancy rates were similar, miscarriage rates, ectopic pregnancy rates, and also ongoing pregnancy rates. Live birth rates are in red here because they are interim results. We are waiting for the last 6 patients to deliver in the next month. So these results are also interim results, but I wanted to share with you the obstetric outcomes in our patient group. Of course, our study was not powered to detect differences in obstetric outcomes, so of course this is a limitation. But in this group, we did not see a difference in preeclampsia or in hypertension. We did see a higher rate of cesarean sections in the artificial cycle group and postpartum hemorrhage, and also a higher rate of large for gestational age. So to conclude, the clinical pregnancy rate with fetal heartbeat did not differ in our RCT between natural cycle fat and artificial cycle fat in ovulatory women. The strength of this study, we believe, is the multi-center RCT design and also the population, because nowadays we get a lot of information from Asia where they can run big RCTs like the previous one within a short period of time. But we think it's more than ever important to also validate these results in our European population. Of course, we also have some limitations. We did not do progesterone measurements or individualized luteal phase support in this study, as this became only standard practice after the initiation of this study. But we think this has not influenced the difference in results because it was not performed in both arms. And then another limitation, of course, is that our study was not powered to detect differences in live birth rate or in obstetric complications. But for the last one, I think it's very difficult for us because you need really very big RCTs like the previous one we've seen. Also in the US, we are waiting for a study that is powered for this. But recently, the EV group in Spain, for instance, they did a study that was powered to detect differences in obstetric complications, but they had to stop the recruitment prematurely because they could not recruit enough patients, and they found it not ethical anymore to continue doing these RCTs with what we know all now. So finally, I would like to thank all the centers that helped us with recruiting patients, and especially the study midwives Marike and Sarah for their effort. Thank you.